hospitals across India?
Absolutely. I think the issue is kind of similar to most other countries where it was thought that the block or the hurdle would be the doctors, because most of the times, for lack of better term, doctors are the worst animals to deal with, and I'm probably there as well. But I think the resistance from doctors has been traditionally thought to be the reason. But frankly, I think there are ways to overcome that. There are always ways of developing champions to, lead the program. Some of them can be first adapters, and then subsequently others can adapt. In fact, so you can come up with some innovative ways of, at least in India, where the junior doctors and other manpower is available who can probably assist them with that if they are delaying in adapting to the system. But I see no reason why technologically we can't do this. I think it should be very easily doable by several of the solutions that are available. And I think it just takes the first one to take the gun and start doing it.
Now, do you think incentivizing it will help? Because I think that's a major attraction in the US, for instance, where the government itself is actually rewarding you for using electronic systems. So a model like that in India, where some kind of incentives are given for utilizing CPOE systems, or maybe even charging the patient for it?
Sure. I think it has to be a combination of rewarding for doing it and penalizing for not doing it, unfortunately. I think that is what would probably work much better than just the reward option, but yes, it would. Everything, I think there's always the question of what is in it for me, but some of it may be direct, that you get something out of it right away, but some of it may be indirect over a period of time. I think it would make a tremendous impact on speeding up the process, making it more error-proof, and it's probably much easier than what most people think it is. In our tele-ICU solution from here to the US, we are actually utilizing various hospital systems, and each one of them have their own CPOEs. In fact, I'm operating on several different ways, and it comes to you once you start using it. It's not a difficult thing to do. But one thing that always comes to any doctor's mind is when you have algorithmic approaches, when you have possible solutions in medicine, sometimes it's not necessarily mutually exclusive. For example, a patient could have a chest pain both from his cardiac situation and maybe an acid reflux. But when you have branches that are going to list some of them, could that lead to issues when...
That is a good question. Thank you. Okay, to answer that, let me take up on bull's feather horn. If a senior most cardiologist and a senior most gastroenterologist see the same patient at the same time, listening to the same set of complaints and viewing the same set of investigational results and all the other observations, minus any of the historical records, what would be traditionally their approach? Is we would go by the differential diagnosis, we'll start eliminating which is the most obvious or easy to eliminate, so that you start focusing on what can be best done. That's exactly what I meant as Watson is undergoing internship. It is not here to replace. It is not super intuitive that bolt out of the blue it learned. What it has learned is whatever is available which is published in starting from PubMed all the way till the entire Wikipedia, encyclopedias, almost every single medical journal which you can think of. It digests the information prior. That is, it has already digested the information. As the new information comes in, it keeps digesting. That is, it is as current as the last 1 minute. Right? That is what we call them as the knowledge. And then you have a patient who is presenting with the current condition. And it approaches from two different angles and comes back and says that from the given understanding or the given results, I presume that these are the most probabilistic ones. And then it still leaves it to the cardiologist or to the gastroenterologist to decide what you wanted to do. It is never is going to replace, or it is never is going to decide. It is possibly a Google, if I may call so, an enterprise, a medical enterprise kind of a search algorithm, search system. It's not even an algorithm. I mean, because you can talk to it.
Sure.
And it'll give you answer back in 3 seconds. So you can keep answering question. If there are no other questions, I would like to thank.
Hello,
Yeah?
I have a question.
One last question, yeah?
I have a question to you. You have a decision support system. I think it's similar to that kind of solution, right?
Can you repeat?
To know like how the Watson is different from like other decision support systems available in the market.
Oh, okay. If I rephrase the question correctly, what is the USP of Watson's system, and how is it different from other diagnostic decision support systems available in the market? Am I right?
Yeah.
There is no diagnostic decision support system which actually learns from the existing medical knowledge. To my knowledge, maybe if I'm wrong, you can correct me. There isn't a single encyclopedia or a medical encyclopedia which is available, which also takes patients' data. So there are two components. In fact, in one of the slides where I had mentioned, there is a knowledge base and then there is an evidence base. The current systems are all about evidence base. What we are bringing in is the knowledge base as well. That's what I said. It is as current as the last 1 minute.
Okay, thank you.
Right? And it answers in 3 seconds. By the way. Thank you. Thank you for this wonderful session, and thanks to all the speakers. Thanks for the audience for an early morning session typically.
Well, this brings us to the end of session 7, and we now begin with session 8, which will discuss the education and training aspect. And the chairperson for this particular session is Dr. Dilip Mathai. Dr. Dilip is Professor of Medicine and the head of department of the Christian Medical College in Vellore, and he has received over 80 operating research grants from world-renowned institutions. His goal is to develop an accredited postdoctoral training program in India. Dr. Mathai, please take it away. Thank you.
Thank you, and thank the organizers for having invited me to be the chairperson for this session. The term doctor is derived from the French word docere, which means to teach. Doctors have to teach their patients, they have to teach their colleagues, and they also have to teach their students. The introduction, and we in India have got very limited number of trained faculty to teach our medical students. We need 60,000 doctors each year in our country, and currently we have less than 30,000 graduating. We need 600 medical colleges, and we have only 258 currently now. So, looking at this, the challenge is enormous. Yesterday, when we were listening to the talk about telecommunications as well as the innovations, globalization of healthcare, two outstanding thoughts came to my mind. One was when Mr. Sumant talked about intelligent clinical systems and analytical clinical systems, where you have the 4 P's as he was referring to. One is being proactive, the second one is being prospective, third one is being predictive, and the fourth one is pattern recognition. How can we bring these intelligent systems into medical teaching? We also had Mr. Saurabh talking about the future hospitals, 2.0 hospitals, where you have the definition of a hospital, according to him, current definition, was a place where you diagnose and treat. And then he moved on to say the future hospitals where you will have a better clinical outcome, where you will make it more patient-centric. In other words, improve the quality of care. And we also add one more term to it, the patient safety. Today, medical education means that we have to ensure that the patient is safe. So how do we bring in technology, particularly computer technology, to aid us to truncate the training process? The making of a physician takes about 12 years. Making of a surgeon takes about 15 years. How do we bring these skill sets and truncate them so that we can have large number of doctors and teachers in this country? Now, finally, we have 6 speakers. We inherited a time loss of about 30 minutes. Now, we've got 3 international speakers and 3 Indian speakers. I cannot restrict their time because they have a message to tell us. And I think we should pardon them and me as the chairperson if we exceed our scheduled time of 12 noon to 12:05 or 12:08. The purpose of this meeting and the purpose of this session is basically, we talked about globalization of healthcare. I would like to take this session as harmonization of healthcare education, both in Indian scenario as well as in the global scenario. And for this, I would invite the first speaker, Professor Jai Mohan. Professor Jai Mohan is from the University of Kuala Lumpur, Malaysia. He is a professor of pediatrics, and then he added on into his specialization health informatics, and he continued to work there in the Learning Resources Center at the university. He was also associated with the Ministry of Health, Malaysia, and has had various stints as professor of pediatrics at the Seremban Hospital. He was head of pediatrics, Malaysia's first paperless and filmless hospital at Selayang before retiring from government service 10 years ago. So you'll have 15 minutes. I'll make sure. Okay.
Of this meeting, for giving me this opportunity to share some information with you and to learn from all the other speakers and participants who are present at this meeting. The title, E-Learning, Out with the Old, In with the New. I'm not going to explain it now, but it should become obvious as I proceed in